Now I'd like to review some case studies with the RTD wound dressing. In all of these case studies, the cases obtained full closure of their chronic wounds. This case study is of a Pyoderma Gangrenosum in a 64-year-old woman who lives in a nursing home. And you can see that there are some deep areas of a crevicing in that original slide from October 18th. And you also can see that you have some methylene blue staining here. It looks like methylene blue. That's not from RTD. That is from a previous dressing that was tried. And what you can also see is that these areas vary in depth. And here's, for example, a very deep crevice. And what you're going to want to do is pack RTD in this wound, and you're going to want to abut it against the edges of the wound. So they went ahead and used this RTD because it's perfect for pyoderma. You have analgesic, antimicrobial, and antifungal effects. So you have a lot of positive reasons to use this RTD with Pyoderma Gangrenosum. As you can see on November 21st, 48 days later, she has complete healing. So she went for a year without any healing, with very expensive treatment, and now she's completely healed in about a month and a half. This is a very typical diabetic ulcer. You can see on January 28th that this patient had a surface wound with a lot of demarcation around the ulcer. This is a stage 2 diabetic ulcer, and that also had the following areas of compromise. It was a non-healing wound, which had no progress within the last year with an infectious disease specialist. The infectious disease specialist couldn't suppress what infection he thought was there with IV antibiotics. Now, we discontinued the IV antibiotics and began RTD, placed it on the surface of the wound, wrapped it with a cling, and changed it every 3 days. As you can see, on February 23rd, it was completely healed. And what's really interesting is even the area of demarcation around the original ulcer is gone. There's a lot less edema, and you can see that this patient, as a 60-year-old male, had been non-ambulatory on that leg in the beginning on January 28th. But as that leg healed, the edema went down, it became possible for this patient to ambulate. And that's an also very important goal for geriatric patients. This pressure ulcer is a typical coccyx wound. This is an 82-year-old female who was non-ambulatory and was incontinent of urine and feces. Pretty typical case. And they had this coccyx ulcer for a long time and just felt that it could not be kept uninfected or it would not be able to be healed because of the incontinence. Now, we didn't put a Foley in or do anything else. We just treated it with the RTD, cut it to fit the size of the wound, and then progressively as it got better, we needed to use less and less. And you see that on November 23rd, she had complete healing of this diabetic ulcer. That's about 3 months. So that's very great results. This is a surgical wound. This is a 36-year-old male with a non-healing post-surgical wound. This patient has a history of laryngeal myofibroblastic tumor with chronic dyspnea, so he has hypoxia. And he's a non-smoker and is height and weight appropriate. What you can see is that he had a subcutaneous lipoma excised on February 13th, and he went to the wound specialist for care on March 12th. What was incredible was he was on Aquacel AG for 21 days, no change, a calcium alginate product for 42 days with no change, an Inidine product for 27 days, no change, and the Aquacel AG for 5 days more and no change. Then finally he got on the RTD wound dressing and he healed in 11 days. So he had no change in his wound until he started to use the RTD. This is the same surgical wound, and you can see on the bottom of that slide the graph that shows there was no change with those other dressings, but when he got on the RTD, he basically healed his wound. You can see that he didn't know how to place it in the wound. He was a patient, but he basically just placed it over the wound. And so on June 21st, there's the RTD that came off the wound, and you can see all the dead cells and material that were removed. Now look on June 27th, you can't even see where that wound was. So that is a very good way in which RTD can completely heal a wound. So this lady is a traumatic knee. She's a 40-year-old patient who basically fell in a parking lot and had a wound to her knee, which, as you can see on the first visit, had heavy eschar. And on the second visit, that eschar was mostly removed, and then it was placed, RTD was placed, and a wound vac was placed, and you can see all the areas there that are now uncovered. And this is a good example of what I was talking about when I said that the wound can get bigger, but it has to get bigger and have all of that dead area and bacteria out of there before it can heal. So that last picture shows you the cleaned up wound and all of the areas that need to be packed now. You can see that 2 weeks into RTD with the wound vac, it's much better, much more granulating tissue, much less of a deeper wound. 4 weeks later, you see that it's having good granulation bed. On March 29th, you see a very nice, almost surface wound that has been cleaned up. And on April 16th, you see just basically almost closed wound that they place RTD on without the wound vac. And then on May 16th, you can see how much it's shrunk. And now you have a wound the physician felt was already healed. We told her to continue with the RTD until she had full closure. And that way you minimize the scarring.